minutes. Yeah. I'd like to call the Health Subcommittee to order. Will the clerk please call the roll?
Representative Boyd. Here. Representative Byrd. Representative Freeman. Here. Representative Hall.
Here.
Representative Jernigan. Representative Kumar. Here. Representative Marsh. Here. Representative Ramsey. Representative Sherrill. Here. Representative Smith. Here. Representative Terry.
Here.
Chairman, you have.
All right. Thank you. And before we get started, do any of the members have any personal orders? Okay, seeing none, we have a pretty robust calendar. First item on the calendar, House Bill 1202, has been rolled to the final calendar. That brings us to item number 2, House Bill 778. Let's see, it's Leader Gant. Okay. You're carrying it? Okay. My understanding is that Chairman Kumar is carrying House Bill 778. You're recognized. You have a motion and a second.
Thank you, Mr. Chairman and committee. This bill solves a problem that we have in the sense that when TennCare approved pharmacies provide COVID vaccination, the federal law requires that they should be registered with TennCare, and that is not common. So this bill will establish a statewide collaborative practice agreement between the Department of Health and the pharmacists so they can continue to provide that service.
All right. Thank you. We have an amendment 004410. Is that correct?
Yes.
Okay, you have a motion and a second that rewrites the bill. Is that the explanation you gave us? Was that actually the amendment explanation?
That is true.
Okay. Any questions on the amendment? Representative Smith, you recognize.
Thank you, Chairman. And Chairman, one of the things I asked the department when they came and worked this bill is pharmacists, I know, are giving COVID vaccines, but have we had this mechanism in place for flu vaccines, for other shingles vaccines and other things like that? Is this something that will apply only to COVID, or will this be something that applies to all other vaccines that pharmacists give? Thank you, Mr. Chairman.
Chairman Kumar, you recognize.
Thank you, Mr. Chairman. The way this is written, it applies only to COVID vaccines.
All right. Any further questions on the amendment? Okay. Seeing none, we are voting on amendment 004410. All those in favor say aye. Aye. Opposed? Okay. Ayes have it. We are back on the bill as amended. Any further questions or comments? Seeing none, we are voting on House Bill 778. All those in favor say aye.
Aye.
Opposed? Ayes have it. Bill goes on to full health.
Thank you, Chairman and committee.
Thank you. That brings us to item number 3, House Bill 1350. Chairman Vaughn, you recognize. We have already had a motion and a second. We have gone out of session to have some testimony. If you want to go ahead and refresh our minds on the legislation, and I think there are some folks that wanted to talk.
Yes, sir. I'll be glad to. Mr. Chairman, what this bill does, and I always hate when people start the presentation that way, what this bill does. Well, we know we're eventually going to get there. This bill clarifies who is able to use the term anesthesiologist. And the basis behind this is the recent recognition by the dental board of the term dental anesthesiologist. There's already codified who is an anesthesiologist. People are starting to, outside of that code section, are starting to call themselves modified anesthesiologists. And one of the things I'd like to point out is that I find that some of the most confusing times are when things are almost the same, but they're not. You know, the first brush you see something, you think, wow, that's that's what that is, but then the more on further investigation, you find out there's indeed some critical differences to it. I think that that's where we are with this, and I believe you're right, Mr. Chairman. I think that we've got some folks that want to continue the discussion on it.
All right, thank you. So without objection, we will go out of session, and we have, looks like 4 folks that would like to testify. So without objection, we'll go out of session. We have Julie Griffin with the TMA.
I don't know if I remember how to do this.
I think you're good.
Can y'all hear me? Okay. Julie Griffin, Tennessee Medical Association. I really applaud the sponsor of this bill for bringing the legislation. It is a confusing time in healthcare. Patients are confused about just about every aspect of their healthcare. And I think that what this bill goes to do is make sure that we don't bring any more confusion to what's already there for patients. Patients, when they hear the term anesthesiologist, they anticipate that they are seeing a medical doctor who has gone through all the training that an anesthesiologist goes through in order to know that they are being seen by those that are appropriately trained. To allow for a dentist who may have some training within anesthesiology as part of it doesn't make them an anesthesiologist. And I think that this bill goes to make it clear that those that do not have that training do not confuse the patients that they're seeing and make patients feel more secure in the care that they're being given than they may otherwise have done.
Thank you. Any questions for Julie? Okay, seeing none, thank you. All right. Next on our list is a Cynthia Kiefer. And for the record, just state your name and who you are and into the microphone, who you're with.
Many diagnoses. But first, let me say thank you, Mr. Chairman and members of this committee for letting me speak to you this morning. I'm the proud parent of a handicapped son. He has been diagnosed as profound mentally retarded, global developmental delays, autistic, and he is nonverbal. So we have no communication. I am unable to communicate or explain things to him as they occur. At an early age, he had one very bad experience with the dentist filling a cavity with no anesthesia. It was traumatizing for him in every way. Every attempt to visit a dentist thereafter was met with very aggressive behavior. And at this point, you can think about a bull in a china shop, flailing arms, kicking, whatever. We then moved to having his dental work done in a hospital under complete anesthesia. This worked extremely well until that dentist died. And thereafter, this practice of doing dental services in the hospitals was no longer accepted by insurance companies. There are very few dentists who will even work with special needs or our handicapped population. Out of that very small number, only 3 offer twilight sedation services that will be covered by TennCare. TennCare and or other insurance companies will not cover hospital dentist anesthesia, period. My son cannot tolerate twilight sedation. Twilight sedation is a very light sedation where you're still somewhat awake. You're not totally asleep. I firmly believe we should all have the privilege of choosing our dentist. This is not a case for dental care for the special needs population. He went over 2 years without seeing a dentist. Now remember, he's nonverbal, so he cannot tell me he has a toothache or something hurts in his mouth. And I don't know about you, but toothaches are pretty painful. So we neglected his oral health care, basically, and that can lead to many threatening health issues, as I'm sure you're well aware of being a member of this committee. So as a caring mother, I called 2 of my personal friends who were medical anesthesiologists and begged them to come and sedate my son so he could have a dental checkup. And they both apologized and explained to me that they work for an anesthesiology group, and that group has privileges at specific hospitals, but not a dentist office. So they were committed to this group that was not able to provide the service that I needed. So I knew what I needed. I just didn't know how to find it. So I went on the internet and I searched dentist anesthesiologist. And by the way, that term is not confusing to me one bit. I knew what I needed. And I found this group called Nashville Office-Based Anesthesiologist, and I called them immediately. And so for the last 3 years, I've used them in providing the necessary dental checkup, cleaning, cavity filling, and all the other things afforded to all humans. I have found dentist anesthesiologists to be professional, caring, very dedicated to their service. There need to be more of these to care for the thousands of patients who need this kind of service. They enable the dentist to focus on his work and not the anesthesia portion. And this also saves money because there are no hospital costs. So thank you for your time and consideration of this much-needed service in our community.
And thank you, Ms. Kiefer. Do we have any questions of our testimony? Is anybody? Yes, Dr. Terry. Yes, Dr. Kumar.
Thank you, ma'am. Thank you for coming to testify. It takes a lot of courage considering the circumstances you're faced with your child. And I think you have the sympathy and support of the committee that your child continues to receive the care he needs. I don't think this legislation will prevent those dental anesthesiologists, as they are called at this time, from practicing. They may practice under a slightly different name, but they will definitely continue to practice and provide the care. And that's our duty, too, to continue to have that care available to your child and people in similar situations.
So you're saying if I looked up dentist anesthesiologist in the internet, I would still find what I look for this time?
Dr. Kumar, are you familiar with the question?
Thank you, Mr. Yes, I would need help answering it. I don't know if this bill is going to prevent those people from calling themselves dental anesthesiologists. That's a question for legal. But what I'm saying is whether they practice under that name or another name, they will definitely continue to practice and provide the care.
Well, thank you. I appreciate that.
Ms. Kiefer, does I missed most of your testimony, I'm sorry, but does the dental anesthesiologist work from a specific office?
They come to the office and provide the anesthesia services needed for whatever process is taking place. Yes. And in my son's case, it was the dentist, and he needed to have his teeth cleaned. He hadn't had them cleaned in 2 years.
Yes.
He would walk into a dental office and smell and see that chair that is specific to a dentist's office, and he will go berserk.
And that is my understanding, I think, of most of these. They operate out of a central office, and they go to different places to practice. And I think that's one of the great benefits, is that they get to go to areas that typically aren't supported by a brick and mortar anesthesiology presence. So
you're exactly right, Mr. Chairman, yes. And that is a huge deal to me, because like I said in my testimony, we should all have the privilege of choosing the dentist we want to go to. And if I only could go to this place that served dental anesthesiologists, and the dentist I wanted as my dentist was not a part of that office or that complex, then I would still be out of luck. And I would still not be able to have the dental procedures done with anesthesiologists, with the dentist of my choice.
Yes.
And I think that's the hardest problem I have as a parent, is the restrictions on who I see as a dentist and who I see as a doctor are very limited, because TennCare just doesn't pay enough and doctors don't want to do it. Yeah. And if you do find one that will do it, and then you can't find the anesthesiologist to work with them, then you've gotten nowhere, really. Yes. You're back at square one. It's very frustrating as a parent, and it's very difficult. And believe me, we've got a lot of other things to worry about than trying to find the dentist we want and the anesthesiologist we want.
Do you have further questions of Ms. Kiefer? If not, we will thank you for your testimony very much. And I think next on our list is Dr. Matt Yezerski, Doctor of Medicine and Dentistry, a dentist. And I'm sorry, last week I think you flew back from Florida and then we didn't let you speak. Okay. If you'd identify yourself, sir, for the record.
Yes, thank you, Mr. Chairman, and the members of the subcommittee for hearing my testimony today. My name is Matthew Yezerski, and I'm a dentist anesthesiologist. So this bill is of critical importance to my profession and my practice. I've been asked by Dr. Philip Kemp, the president of the Tennessee Board of Dentistry, to begin my testimony by stressing aspects of a letter that he sent to this subcommittee, as he couldn't be here himself to testify today. His letter states that the Board of Dentistry, whose members are appointed by the governor, are tasked to serve and protect the public. The board has legal authority granted in multiple places by Tennessee Code to recognize dental specialties and their specialty designations. They did this in 2020 after a nearly 2-year process that brought Tennessee in line with the national standards by recognizing dental anesthesiology and the term dentist anesthesiologist. So this bill would diminish the work and authority of the Board of Dentistry. Dr. Kemp also recognizes that this bill would disenfranchise members of our profession who seek to raise the standards of safety in dentistry and make it difficult to recruit leaders in our field to a state that doesn't recognize our earned credentials. And I appreciate and agree with Dr. Kemp's statement on this matter. As for me, I'm a dentist anesthesiologist. I've resided and practiced in Middle Tennessee since 2012. And I'm not here to represent a trade organization or a lobbying group. I'm here to represent my practice and my patients. And if you hear nothing else today from me, please hear this. If this bill is allowed to pass as written, it will have unintended consequences that affect real people, including dental professionals and their patients. It will result in limiting access to safe, affordable, and timely anesthesia care for our most vulnerable communities, specifically patients with special needs, like you heard, and children on TennCare. And this TennCare Medicaid issue is significant. I've waited years for the Board of Dentistry to update our rules and regulations, and by defining our specialty at the state level, we'll finally be able to be approved for TennCare services, where some children are currently waiting over 6 months with a backlog of patients requiring anesthesia. And across the state, hospitals and surgery centers are cutting dental services in favor of more lucrative procedures. In rural communities, the situation is already dire. As TennCare numbers grow, so do wait times and the distances that children have to travel to seek adequate care. And so instead of looking at ways to reverse this trend, this bill actually worsens the crisis. So that you know a little bit more about me and the training of a dentist anesthesiologist, after my undergraduate education, I completed 4 more years to earn my Doctor of Dental Medicine degree. I then continued my education with 3 postdoctoral years of residency training at an accredited program for dental anesthesiology at Stony Brook University Medical Center in Long Island. So our training was completed in tandem with medical residents, trained by physician anesthesiologists and dentist anesthesiologists. We provided anesthesia at a level 1 trauma center for every type of surgery: general surgery, orthopedic, neurosurgery, pediatric, from appendectomies to organ transplants. We took 24-hour call, we served on trauma teams, we served on code teams and difficult airway teams. Our training was extensive, but our training is also highly specialized for dentistry. It's not identical to medical counterparts, but please keep in mind that differences in training does not mean inferior training. Our training is specialized to fill a unique need for underserved populations. Dentist anesthesiologists are the only anesthesia providers whose training sets requirements and benchmarks for treating patients with special needs. Dental anesthesia programs also set requirements for off-site, office-based anesthesia rotations, uniquely qualifying us to provide anesthesia at the highest possible standard in the dental setting. So after all this training, I moved with my family to Middle Tennessee and for nearly a decade served the dental community with the goal of raising the standard of care. And for the first 5 years, I was the only dentist anesthesiologist in the state, which may be why our medical colleagues aren't familiar with our level of training in Tennessee and the designation of dentist anesthesiologist. I built my practice by educating and providing anesthesia services for over 100 dental offices and treating thousands of patients who couldn't have been seen otherwise. So if this bill moves forward as written, it would indicate that my training is somehow, even though I completed it in parallel with medical residents, somehow I'm less than my physician colleagues and not worthy of the title dentist anesthesiologist. Not only that, this bill would state that my training is somehow inferior to a dentist that completed training over 50 years ago, even before residencies had accreditation standards. So we've been told that using the nationally recognized title dentist anesthesiologist could potentially confuse our patients, as if we have a desire to pass ourselves off as physician anesthesiologists. But the truth is we're proud of our dental training, and it sets us apart, and the public should know that. True patient confusion would be if I were forced to call myself a general dentist or some other name when my practice is limited to the field of anesthesiology. There is no other recognized term for our level of training and practice except dentist anesthesiologist. So let's discuss that term, dentist anesthesiologist.
Dr. Juzerski, we're coming up on time, but go ahead
Yes,
and
sir.
finish
Well,
your
I'll
thought, sir.
finish this point. This is stick with me on this one because this seems like I'm wading into the weeds, but this is very important. This title's not new. It is a nationally recognized specialty by the American Dental Association and has been used by national organizations and federal agencies for decades. Centers for Medicare and Medicaid Services, CMS, are national provider identifier taxonomy codes, which every healthcare provider they're required to accurately use, define dentist anesthesiologist. The U.S. Bureau of Labor Statistics, the U.S. Department of Education, and even the American Society of Anesthesiologists recognize the term. And it was implied last week that the ASA doesn't recognize the term and isn't aware of it, but from the ASA's own website this morning, I printed off practice guidelines from 2018 that were published in the journal Anesthesiology, the ASA's official journal. And not only does that publication recognize our American Society of Dentist Anesthesiologists, but they also surveyed our members. They also collaborated as co-authors. And in the practice guidelines of the ASA, we're kind enough to provide a list of recognized providers. And that includes physician anesthesiologist, nurse anesthetist, and in black and white, dentist anesthesiologist. I'll close by mentioning the fact that this bill is going to do something unprecedented between our professions. Tennessee already recognizes all other dental specialties and their practices and the modifiers before those recognized terms, including oral pathologists, oral radiologists, and oral surgeons. So do those titles and modifiers that are already in use today cause confusion, or do they provide clarity? And will this bill set a precedent to strip titles from other dental specialties? There's a simple way to fix this, and that's by using the existing clause that mentions a dentist who completed a residency program from 1963 to 1977 can use the term anesthesiologist to include all dentists who meet this level of training. So if you have any questions, I'd be happy to answer them. I thank you for your time and consideration of these facts.
Any questions? Yes, Chairman Boyd.
Thank you, Mr. Chairman. Matthew, appreciate you coming to talk today. I've heard a lot about confusion, that the patient might be confused. I mean, have you ever been called by a customer or a patient to go in and do a surgery in a hospital or something to perform anesthesia for that?
No, I haven't. My license is through the dental board, and so I provide anesthesia for dental services. And so when a dentist calls me to say, hey, can you please come in? I've got a patient who can't be seen any other way, that's who I'm there to see, and they know who they're coming to see.
Chairman Boyd.
Thank you, Mr. Chairman. If someone got confused and they did call you, would you go in and do a surgery like that, or you would tell them that you don't do that? Stick strictly with dentistry?
Yes, I provide anesthesia for dental services. I'm restricted by the fact that I'm underneath I'm governed by the Board of Dentistry to provide procedures only for oral procedures. So yes, for dentistry.
Chairman Boyd.
Thank you, Mr. Chairman. And Matthew, in your opinion, is there really any confusion out there, or is the fact that the word dental was before anesthesiologist, does that make it pretty clear that what kind of practice you had?
In my mind, it makes it incredibly clear. There hasn't been any confusion. The only confusion comes in the fact that there's so few of us here in Tennessee. And I wish that there were more of us because, like we heard, there are lots of patients who need this service. And so if there were more of us, then I'm sure that any of the confusion would be cleared up very easily.
Dr. Kumar.
Thank you, Mr. Chairman. I have a question for our legal eagles. Considering that Dr. Yasirski has had a recognized or approved residency in anesthesia, he is entitled to use the terminology dental anesthesiologist, isn't he? Is he not? Because he has had a full residency,
I recognize the staff.
approved residency.
Matt King from the Office of Legal Services. Chairman Kumar, the subdivision that speaks to having completed a residency anesthesiology falls beneath another subdivision that speaks to physicians. So it's a two-part, so they'd have to be a physician, a licensed physician who's completed a residency in anesthesiology and has practiced primarily limited to anesthesiology. The other part speaks to dentists, so it's bifurcated in that one part speaks to physicians with those qualifications. The other part speaks to the dentists who have completed the residencies back between 1963 through 1977.
Chairman Kumar.
Thank you, sir. So those who completed a residency after 77 are not allowed to call themselves an anesthesiologist?
Under the bill, they would not, no, sir.
Thank you for clarifying that. Considering that they've had anesthesia training, what would they be allowed to call themselves?
Asking of.
Legal.
Legal, you're recognized.
Chairman, I wouldn't want to speculate on other titles. However, the only thing the bill would prohibit is just the use of the one term anesthesiologist. It doesn't speak to any other prohibition.
I see. Well, thank you for clarification. So it does not clarify, since your residency at Stony Brook was after 77, so this bill will take away your ability to call yourself a dental anesthesiologist.
Correct.
And so you will have to choose another title that explains it, dental anesthetist or something like that.
And yes, sir. That's the point that's really tough, is that when we're dealing with malpractice and liability coverage, insurance carriers, CMS, Medicare and Medicaid services, the only term that's recognized is dentist anesthesiologist, and that's at a national level. And so there's no such term as dentist anesthetist or anything else you can come up with. There just isn't something else that recognizes what we do in our level of training.
Dr. Kumar.
I would just end by saying that anesthesiology to me means more than just putting people to sleep. It has other disciplines in it, such as critical care, which is very, very important in a hospital setting, and pain treatment and so on. So I think anesthesiologists rightfully can claim that their specialty covers so much of it, and people who are limited to only dental anesthesiology may not call themselves. So I think that is their claim. And I see that. I can see the fact that it is such a wide specialty that provides other things, so they have chosen to do so. Thank you, Mr. Chairman.
Thank you, sir. Any other questions? Yes, Chairman Marsh.
Thank you, Mr. Chairman. And my question would be, if this bill passes, will this limit what you do now? Would you not be able to do your present job and everywhere you go?
So it limits a few things. One, it doesn't take away my general anesthesia permit, okay? So, I can still see go to a dental office and see patients who can afford to pay anesthesia fees at the dental office. But what it doesn't do is it doesn't allow me to, if I don't have this designated specialty in Tennessee that the dental board has already attempted to recognize, then I won't be able to have accurate NPI numbers, which go along with insurance billing. I wouldn't be able, like I had mentioned, to be able to see TennCare patients. So 90% of the kids at these dental offices that I go to, I can't see because they have to wait and go to a surgery center or the hospital. But I'm able to see the kids with wealthy parents who can pay for the treatment. And so not only, this allows me to continue to use my name, which I've used for 10 years as far as advertising and being able to let people know what my credentials are, but it would limit my ability to treat other patients as well.
Leader Marsh.
If this passes, could you be like dentist specializing in anesthesiology?
Again,
that's just a play
Dr.
on words.
It turns into this play of semantics, but the problem is when you take away the actual term dentist anesthesiologist, that's the defined term by CMS. That's the defined MPI taxonomy code is dentist anesthesiologist. If you start saying, well, in Tennessee, everywhere else we're dentist anesthesiologists, but Tennessee you have to say you're a dental specialist in the field of anesthesia, it just doesn't work. And that's what's kind of funny about this is that there's a carve out for a dentist who finished a residency 50 years ago, but if you just change that, if you change that to be able to say someone who finished a postdoctoral accredited anesthesia residency, perfectly fine. And then all of a sudden everybody's happy and we can continue to see the patients that we've been able to see and provide more care for patients. So that's where it comes to be kind of frustrating to watch it from this side.
Thank you.
You're welcome.
Thank you, Mr. Chairman.
Representative Freeman, you wanted to be recognized.
Thank you, Chairman. My question deals with those codes and the billing. Do you get paid the same amount to perform the anesthesiology as someone who is an anesthesiologist in a hospital setting? Is the cost to TennCare and insurance, is it the
Dr.
same?
Uzersky.
The cost is actually, because we're able to provide it safely and in a timely way in the dental office, you actually don't have to charge facility fees, which are thousands of dollars for every procedure that goes. So when a child goes for TennCare to go to a surgery center or to Vanderbilt or any hospital across the state that sees these patients, then they actually get charged for the anesthesia and then also a higher facility fee as well. And so when we do that in the office, it actually lessens the cost for the state if we were to be able to see these TennCare patients. By, from my calculations, about $1 million per dentist anesthesiologist, you could lower the cost of TennCare.
Further question?
Yeah,
Representative Freeman.
Thank you. And I guess what I'm really getting at is when you bill, do you bill under a code dental anesthesiologist, and is that reimbursed at a lower rate than a traditional straight anesthesiologist?
Again, the issue right now is that until the dental board's rules are finalized to recognize our specialty in Tennessee, I'm not billing under the term dentist anesthesiologist. I'm billing as a general dentist who provided a service. And right now, like I said, all of my patients are fee for service. Ms. Kiefer has to pay out of pocket to be able to have our services done, but she's willing to do that because it's 1/10 of the cost of going to the hospital. And so if the bill allows us to be called dentist anesthesiologist and the dental board's rules can go through as they've approved, then that would allow me to then bill insurance and hopefully be credentialed through TennCare as well.
Representative Freeman, anybody else have any questions of our dental anesthesiologist? If none, thank you for your testimony.
Yes, sir.
Oh, pardon me. Okay, we now. Does she want to sit with him?
Whenever you find that appropriate.
Okay. Well, let me go ahead and do Tasha.
Okay.
Yeah. Okay. Okay, thank you very much, Dr. Uzersky. We appreciate you being here. Sorry we missed you last week. We've got a request from Tasha Alexander, Tennessee Association of Nurse Anesthetists, and then we've been asked to have Julie Griffin back up from the TMA. So we'll, no objections. Introduce yourself, please, for the record.
Thank you, Chairman Ramsey and committee members. I appreciate the opportunity to outline the concerns of the Tennessee Association of Nurse Anesthetists to House Bill 1350. My name is Tasha Alexander. The genesis of this bill, as it has already been presented, is that two healthcare provider groups could not find common ground on what to call in the use of the term anesthesiologist. But the potential impact of this bill goes beyond those two groups to other healthcare provider groups. Most importantly, though, we would like to point out that this bill does not promote nor does it contribute to advancing solutions on substantive issues facing patients and healthcare delivery in Tennessee today. As healthcare providers who have served alongside many other healthcare providers in the most significant global health pandemic in more than 100 years, TANA and its more than 2,300 CRNAs and student members believe the efforts of our healthcare colleagues and the legislature are better served by keeping our focus on patients and how to better serve them, not fighting over whether one group gets to use a word that describes a specialty or not. TANA considered all perspectives on this bill, including member input, other state experiences, as well as the short-term impact and the long view. The primary concerns expressed by our members were, how could this impact our profession in the future? And how does this bill serve patients? First and foremost, TANA and its members are committed to the overarching priority of patient care. The state of Tennessee has a system of licensing and regulating healthcare providers through its regulatory boards. These regulatory boards are vested with the responsibility to protect the public, including determining the appropriate standards of practice in an effort to ensure the qualified professional conduct, whether that be a physician, a nurse, or a dentist. Another essential element of patient care is that a patient should be adequately informed of a healthcare professional's licensure and other pertinent credentials through appropriate mechanisms. Tennessee, by law and rule, already sets forth rules and requirements for practitioners related to informing and protecting the public. The very statute that this bill amends outlines in detail the requirements for a healthcare provider to display and inform a patient about his or her licensure and specialist designation in facilities. Licensure for healthcare providers in Tennessee is based on meeting the qualifications of the profession, i.e. physician, nurse, dentist, pharmacist, etc., not the descriptor term for a specialty. State law should not restrict the use of the descriptor term anesthesiologist or any other descriptor term to a single profession. Many other healthcare professions recognize the use of descriptor terms for specialties. Orthopedic physician assistants, radiology assistants, psychiatric nurse. Those are some examples from the Tennessee Code. Today, one group is asking the legislature to restrict the descriptor term for its specialty, but what group will be next, and what precedent are we setting for patients in the future? Transparency and accountability in healthcare should help inform patients and the public and promote patient safety and choice. Informing the patients includes recognizing specialties within professions. Prohibiting the use of the descriptor term does nothing to inform the patient or encourage transparency in an already confusing healthcare system or promote profession accountability. TANA holds its healthcare colleagues in the highest regard, and we sincerely hope that the discussions will continue outside this committee room to address this issue. But we are very concerned that if it does not, that this bill could impact other interested healthcare professionals, and we don't want to see that happen. For these reasons, TANA and its members respectfully ask that you vote no on House Bill 1350. Thank you for your time.
Do we have any questions of our witness? None. Well, we appreciate your statements, and thank you for being here. We will, if there are no objection, I've been told that Julie Griffin from the Tennessee Medical Association does not want to be recalled. So if there are no objections, we'll go back into session and proceed with questions that we have of Chairman Vaughn. I know you've counted this whole day lost, but
I'm sorry, this testimony that we've heard was so thought-provoking about And, Mr. Chairman, I'd like to say that I think you may have, through the testimony, if you were listening to some of this, you know, when I first got this, it's like, hey, here's a beef between two highly qualified people over what their title that they're going to wear is. But then as you dig deeper and you listen to this and you listen to the testimony, I kind of got a little bit different perspective on it, and it is that one business is trying to expand its marketplace based upon a title that has been rightfully earned by someone else. And that is what I would ask. We're not here, we don't have people here and all these concerns brought forward about a simple beef between professions. What we're talking about is something that is a marketplace with a lot of dollars in it. And so I think that's what we're here is we're here to settle a trade dispute, not a beef over a title. It's a trade dispute. And I think it's a legitimate thing for this legislature to consider. And the last point I'd like to make is that this does not in any way diminish the services that the good doctor and his patients that he provides and they receive. There's obviously that he serves an important role, and I would not be bringing this legislation if I thought that would diminish and take away from that. But to me, it's kind of like, and I'm a simple man. I look at things, and y'all remember when I was a little kid, it was a big deal to me. When Hostess changed, you remember Ding Dongs, the chocolate cakes, and they changed from Ding Dongs to King Dons, the names, and I was just crushed because I thought, man, they took my favorite snack food away. But yeah, they're the same thing. So you can change names of items, and they still provide the same benefit, the same satisfaction, the same service. That's all that we're asking to do here, is to make sure that one group changes their name, but they don't have to change their service. And with that, I'll answer any questions.
Yes, Representative Freeman, you're recognized.
Thank you, Chairman. Thank you, Chairman. I think I was with you until the ding-dong comment. But I guess my main question is, because I feel like you said it is a trade dispute over a name, and then you said it was something about expanding services, and then you said you don't want to take the service. So I just want to make sure that I'm fully understanding the intent. You just want them to change their name, right, but not reduce the services.
That's correct.
In actuality, it is a trade dispute over a non-trademark name, right? That anesthesiologist is not a trademark name, or is it? Am I missing that, or are we getting ready to decide whether or not it's a trademark name after they've already?
While it's not a trademarked name, it is called out in code in Tennessee statute what constitutes being an anesthesiologist is. And so that's why we're here in front of this group to settle this dispute.
Representative Freeman. I think Chairman Boyd, you wanted to be next.
Yeah, thank you, Mr. Chairman. And Chairman Vaughn, I appreciate you bringing this bill, and I've learned a lot about it. I didn't come into this with any preconceived idea of what it was going to be, but after hearing this, I'm hearing it. The conversation eventually shifted to who had the most training or who was the most qualified, and certainly if I was having a serious surgery in a hospital, I'd want someone like Dr. Terry to do that. But I don't think that the dental anesthesiologists are suggesting that they can do that. We've heard about an apparent confusion that doesn't seem to exist. I'm not aware that I've never accidentally got really close to a surgery and then realized I'd accidentally set it up with a dental anesthesiologist. That's never happened. We've learned that that the American Dental Association, that it's a national accreditation, and we continue in this body to index things to national accreditations. But here we are in Tennessee, kind of taking a step backwards on that. And then finally, I would actually say, my colleague from Davidson County said, is this a trademarked or copyrighted word? Well, apparently we're about to do that. Apparently, we are given license. We are given a copyright to the word anesthesiologist. And folks, I don't know that we have to. It's a big word. And it's big enough for two different professions to share it. And I think that the distinction is if you are an anesthesiologist, then you are a medical doctor that performs surgeries in a hospital or some sort of ambulatory surgical center. And if you are a dental anesthesiologist, I think the distinction is obvious with the word dental. So I mean this as much as I can. I hate to oppose your bill, but I'm going to be a strong no on this one.
Chairman Vaughn, I don't know if you wanted to respond. If not, we have, go ahead.
Well, I would offer a retort, Mr. Chairman, to my strong colleague over here. It's easy for us to say that there's no difference, but whenever you're the person who has put in the time, the blood, the sweat, the tears to earn that title, to earn that degree, to serve the time in the residency, going through your graduate medical education experience, you are protective of what you've earned. You don't want to see someone who has established a lesser, and when I say lesser, not less important, but lesser in work, lesser in accomplishment. To be able to rise up to take what you have grabbed and what you've rightfully earned and pull it back down so more people can use it just by adding a modifier on it. And like I said last week, my profession, engineers, have allowed everyone in the world to call themselves an engineer. And I wish we had done this sooner because there is a distinction. We're just asking that distinction be upheld. And then if somebody else needs to provide another qualifier, another title for their services, be a sedation dentist, be whatever you need to do, adequately describe your services, but you don't get to claim someone else's work. And that's where this stems from.
Leader Marsh.
Thank you, Mr. Chairman. And I'd like to ask, in your opinion, if this bill passes, will the dentists and their procedures still be covered under all insurance that they're already covered under now? Is that going to change any provisions on you were covered, but now you're not covered?
Chairman Vaughn.
Frankly, Speaker, I don't know this for sure, but according to the testimony that I heard, that we had and heard today, is that yes, they would. They just would not expand. Their marketplace would not expand as a result of it. That's my understanding.
And I have one other question that brought up last week. This legislation does not have anything to do with veterinarian practice.
No, sir.
Correct?
No, sir.
Okay, thank you very much.
Okay. Chairman Boyd, you're recognized.
Thank you, Mr. Chairman. And when Speaker Marsh asked that question, it was my understanding when I heard the testimony a minute ago that these folks were having to pay cash now for this type of dental anesthesiologist because it had not yet been established for insurance purposes. And so I'm just bringing that up because that's my recollection of what I heard Matthew testify a minute ago.
Yes, and Chairman Vaughn, you're recognized.
No, I have no response.
And that was my understanding of the discussion, that it would in some way impact the ability to be reimbursed for the care. Chairman Terry, you're recognized.
Thank you, Chairman. And to that point, I spoke with TennCare on this issue, and they have informed me that there isn't a rule or regulation that would prevent an anesthesia dental consultant from getting credentialed or paid. Also, I reached out to DentaQuest, and they had informed me that regardless of the outcome of this bill, they could call themselves dental anesthesiologists to the fourth power. It's not going to change their policy. Ultimately, it is about mobile anesthesia services that is at the heart of this. And according to DentaQuest, two of these anesthesia dentists chose not to be credentialed or not to get contracted. So with TennCare, so that's something that in my investigation of what's going on with this, that I think the committee needs to know. I also want to address a few things. Our committee recently received an email from a lobbyist on behalf of the anesthesia dentists with a suggestion of a mandatory language, and in it, the email said, dentist anesthesiologists are proud to be dentists and do not pretend to be otherwise, and indeed they're willing to meet TMA's or TSA's concerns head on. If indeed the real concern is to avoid patient confusion, they would be open to mandatory language that would require that they inform a patient prior to procedure that they are a licensed dentist with advanced training in anesthesiology. The TSA and TMA do not and have never had a problem with dentists referring to themselves as dentists with advanced training in anesthesiology, but they're just not anesthesiologists. And I want to, even in their own lobbyist words, they are licensed dentists with advanced training in anesthesiology. And I want to point to our code, Title 63, a person who shall be regarded as practicing medicine, with the meaning of this chapter, who treats or professes to diagnose, treat, operates on, or prescribes for any physical ailment or any physical injury to or deformity of another. And then it has, beyond that, anesthesiologist is defined as a physician, not a dentist, a physician, that's a medical doctor, who has completed residency in anesthesiology. And then we've heard that, the rest of that by legal services. I want to point out, we've talked about transparency and accountability, and that's what this is about. And on the website for the dentist that testified, it says the anesthesia procedures mirror those received in hospitals and surgery centers. So going back to the definition about practicing medicine, mirror those in hospitals and surgery centers, including airway protection, yada, yada, yada. You can take comfort in knowing you or your child will be continuously monitored by our highly trained anesthesiologist. Not dental anesthesiologist, anesthesiologist. Go down further, they say our anesthesiologist will personally call you the night before the procedure to answer any questions you may or may not have about your procedure. So in transparency and accountability, yes, that is out there. Last point I want to make, received another email that said they need formal recognition to comply with DentaQuest policy and otherwise but would not be continued to be eligible to perform deep sedation on TennCare patients. Again, they can get credentialed. TennCare and DentaQuest said that it's not an issue with adequacy for the network. They can go through a process to get credentialed. Thank you.
Any references, sponsor? If not, and let me answer one question first. I think the question was asked about veterinary anesthesiologist. According to the staff here, they say that heretofore, with the passage of this bill, no one except medical anesthesiologists will be able to use that term. So the veterinary anesthesiologist will be the next ones here. Yeah, Representative Freeman, you're recognized.
Sorry for the continuing questions. Thank you, Chairman. Back to this confusion thing, just to fully beat it to death. I've got several friends who are doctors. I've got medical doctors, I've got PhD doctors, I've got psychiatrists, I've got dentists. And to me, the qualifier there is, are they an MD? Are they a DDS? Are they a PhD? And this confusion question keeps coming up. So is a dental anesthesiologist, are they a DDS? Are they an MD? And if so, I mean, that clarification is already there, right? Is that?
And Chairman Vaughn, I'd be glad to ask that. Yes, the clarification's there. DMD and DDS, Doctor of Dental Surgery, and Doctor of Medicine and Dentistry do designate, and so when you look it up in the phone book, it's obvious. Is that what your question was?
Yes, and so back to this confusion of who you're getting, it would be pretty clear if you've got an MD or a DDS, because I mean, most doctors I know are proud of that designation and are quick to put it at the end of the signature.
Go ahead, you can say it there.
Rightly so, they should be proud.
Chairman Vaughn.
I think you just cut to the heart of the matter, is they are proud of it, and it does mean something. And so are you going to diminish one to the benefit of the other? That's really the question that we're asking here. So I would just end on that one.
And Chair Lady Smith?
Yes, thank you, Mr. Chairman. And Chairman Vaughn, I did not realize that in Tennessee Code Annotated that the practice of medicine defines anesthesiology. Does your bill address, does it make material changes to 63-6-204 or?
Moves it out of the code, puts it in a different section of code.
Stand by. I see so many numbers.
It's all good.
It puts it in a section of code.
Okay.
Yes, if we could ask Matt.
Yeah, Matt, you're recognized.
It is 63.
Chair Lady Smith, the bill does not amend the definition of anesthesiologist that is in 63.6.204. That is a section definition for the practice of medicine. And this bill doesn't touch that.
Chair Lady?
So I just want to make sure because we're either setting up a conflict or we're protecting the existing definition. And so I want to make sure that I understand that this is the definition of practicing medicine with the area of specialty for anesthesiology. And what I'm getting more, talk about confusion, I'm getting more confused as I hear the conflicting testimony that if your bill takes this and puts it into another section of code, are you making it more vulnerable or are you protecting anesthesiology? Because as it relates to the practice of medicine and the healing arts, I would think that if it's limited to one section, limited to the practice of medicine for MDs, that would be an advantage to physicians as opposed to putting it in another section of code. But I'll let legal provide advice on that.
Matt, you're recognized.
Chair Lady Smith, I think, yes, it is correct that the definition that has been referenced in 63.6.204, the lead-in language says, as used in this section. That is the section that deals with the practice of medicine. The bill creates a new subsection in a different area of code in the general provisions of Title 63. And then that uses the same word, anesthesiologist. However, the bill, as we've been discussing, prohibits people from using that term or another term to imply that they are an anesthesiologist unless they meet the qualifications that are laid out in the bill. They're a physician with those qualifications or they're one of those dentists with the past residency.
Chair Lady.
And so what I'm hearing is this panel is about to make a decision as to whether we are redefining anesthesiology, period. Because if it's already in code and it's been there, and I do understand that there are national organizations that are expanding it, but you know, one of the things I've learned in healthcare after having a career in it for 30 years is that we chase dollar signs. This is about the payer model. And it's getting, as I drove here this morning, I heard a commercial on sedation dentistry, and it's very lucrative. And I think I just heard the testimony that this particular dentist chose not to be in network for TennCare and DentaQuest. So I just want to make sure that I understand what I'm voting on, that we are protecting the term anesthesiology for the practice of medicine as it's currently defined with your bill. And if we vote in the negative, that we're expanding that term to be also used as a billable term with insurance for a dentist.
Chairman Vaughn, you're recognized.
I agree with that assessment.
Thank you, Mr. Chair.
Representative Smith. And again, I think you touched on, we wouldn't be here if this was just a beef. This is a money question. This is about dollars. And so and again, the practice, these people provide a great service, obviously. He's obviously this particular provider that's here obviously provides a wonderful service. And nobody's denying that. But what we're talking about is, are we going to allow an expansion of this practice and then this body deciding that dentist anesthesiologists are okay?
And let me make clear, probably the people you heard advertising on the radio are relative anesthesiology. They use that in almost every operatory in an oral surgeon's office. which is a totally different, there's no intubation or anything. It's a totally different and highly regulated portion of the dental practice. So these folks that Dr. Uzerski are not advertising on radio. They're not going to do that. Yes, Chair Lady.
And again, thank you, but again, just making my point that, there is a difference between anesthesia services and being intubated. And there's quite a difference, but that's where the public doesn't know that. And so again, I'm just trying to make sure I understand what we're voting on today, but thank you, Mr. Chairman.
Have a call for, are there any objections to calling for the question? If none, then we will be voting to send this bill to full committee. All those in favor say aye. Aye. All those opposed? No. Noes have it. I'm fear that the bill has failed, and I would encourage everybody to go ahead and maybe get together. We'll have our own summer study and see if we can come up with some sort of a decision between the factions.
Thank you, Mr. Chairman, and I'll have to say that the one thing I have learned here is that no just means not today.
Okay. Stick around. Is Patsy, Chair Lady, Chair Lady Hazelwood, you've asked to be allowed to do a real quick, important bill that may save the world by tomorrow morning. So we have a motion and second on the bill. Pardon. House Bill 130, item 10. Did I hear a motion? Okay, Chair Lady, you're recognized.
Thank you, Mr. Chairman. This is the DIDS bill, and anybody who's been here any length of time has heard me on this soapbox before, so I will be brief. But what this bill would seek to do over time is bring the folks who take care of the most vulnerable Tennesseans, the DSP providers, bring their salaries up to $15. When we reach that point, then what we would seek to do is to tie those salaries into state employees, and if state employees get a 2% raise, these folks would get a 2% raise. We don't want to do that until the minimum is at a reasonable amount. These people are highly, highly underpaid for the work that they do. They could be working at fast food establishments, any number of other places, making more money. And it really is an issue for organizations that do the work of the state to take care of these disabled individuals, because the turnover rate is extremely high, in some places up to 50%. A lot of that is due not only, it's a stressful job, it's emotionally and physically challenging, and then when you add that to the fact that we pay them so very little, it's an issue that we need to address. And the point of tying it to state salaries, it used to be that way years ago, and in a budget crunch, we chose to cut these people back, and we've left them behind ever since. So all I'm trying to do is bring them up to we can't pay them what it's worth for the work that they do, but we can pay them something more reasonable.
Okay. Thank you. Representative Jernigan, or pardon me, Chairman Jernigan, you're recognized.
Thank you. I'm incredibly supportive of this bill. I'm probably maybe the only one on this committee that's actually used DSPs and who have come into my home. And that if you get a really good one, the quality of life that they provide for a person is immeasurable. And they need to be paid for what they're worth. And we're getting to a point to where people turning 65 years old every day is around 10,000 for the next 10 years. So we're getting to a point to where they're going to be incredibly in demand. We need quality folks. We need to pay them for what they do, because especially our seniors and our disabled, they deserve no less. And thank you, Chair Lady, for bringing this bill.
Do we have further questions or comments? And I see it's got a minuscule fiscal note on it, so.
Just a very, very small. We're working on it, Mr. Chairman.
I know you and the governor have it worked out. No other questions. We'll be voting on sending this bill to full committee. All those in favor say aye. Aye. Any opposition? So approved.
Thank you, Mr.
Thank you
Chairman.
very
Thank you,
much.
committee.
Chairman Vaughn, we don't have another hour for you, but if you if you think you can sneak one in here, we'll address item 4, House Bill 231. Have an amendment that makes the bill. I'll take a motion and second on what's the number?
Drafting code
3799.
3799.
Okay. We have proper motion and second. If you'd like to explain the amendment that makes the bill.
Yes, sir. Mr. Chairman, this bill creates a CON carve-out for retired energy workers. The people, it's completely funded by the federal government. What happens is that the population has grown. These are folks who were exposed to radiation in Oak Ridge back in the day, and this allows service providers for this very specialized type of care to administer the services that these folks need.
We have Chair Lady Smith, you're recognized.
And Chairman, just for clarity and for the record, this is a very small population, probably less than maybe 30,000 people, because in the world of certificate of need, when you use the term carve-out, people seem to tighten up a little minute, but this is a very specific population for Department of Energy workers that is not going to be open to the general public. Is that correct, sir?
Yes, ma'am. As of today, we've got 19,282 that have qualified for these federal benefits.
This is a good bill. Thank you, sir.
Further comments or questions of the amendment? We'll vote on the amendment. All those in favor of placing the amendment on the bill say aye. Any opposition? So approved. We're back on the bill as amended. If any of these folks need general anesthesia, where are you going to send them?
There's so much confusion in the marketplace, I wouldn't know where to begin, Mr. Chairman.
Further comments or questions? If not, we'll be voting to send this bill as amended to full committee. All those in favor say aye. Any opposition? So approved. You are still with us, sir.
Thank you, sir.
We're item 5, House Bill 1353. We have a proper motion and second. We have an amendment 4652 that
Yes,
makes
sir.
the bill.
We're all singing off the same sheet of music.
Stand for a motion and second on the amendment. Have motion and second on the amendment. If you'd like to explain the amendment.
Yes, sir. This bill, comes to us from our friends at the Tennessee Hospital Association. What we're attempting to do is codify one of the executive orders that Governor Lee brought forth during the pandemic. What it does is it will allow for nursing graduates who have not yet sat for their RN exam or their NCLEX exam to still be supervised by accredited people within the hospital setting. And so what it does is while these folks are studying to take their boards, they can work in the hospital under a very defined set of circumstances, and it is consistent with what the practice we've had over the past few months.
Okay, do we have comments or questions? We have folks in the audience that are willing to testify if there are questions to be answered. Yes, Dr. Kumar, you're recognized.
Thank you, Mr. Chairman. This has been a common practice, and I still remember nurses who had finished their training but waiting to take their boards wearing a badge called GN, graduate nurse, and they worked with us in a very satisfactory way. It was also in the setting of the same hospital, same ward where they had been doing their learning, because nursing is so clinically intensive that there is not a whole lot of transition involved. And I think that's, I was surprised that that practice had been discontinued, and I think it does our profession well, needing the manpower needs that we have today, that this will be good for the professions.
Chairman Vaughn.
Yes, sir. And I'm glad you brought that up, Dr. Kumar. What this is a portion of kind of a workforce development program for the medical industry. We've seen how we've been shorted, not just with nurses, but again, we spoke to you about the laboratory personnel. Now we're talking about, I'll be back with the doctors with regards to that. But this is workforce development training for the medical profession, and we think it's something that's sorely needed.
Further comments or questions of the sponsor? If not, we'll be voting on the amendment to place it on the full bill. All those in favor say aye.
Aye.
Any opposition? Back on the bill as amended. We have comments or questions. Chair Lady Smith.
I would just say that this is what I did when I graduated from UT Knoxville. And this does not prohibit a university hospital or a private hospital from having, or any other entity from creating their own type of specialized training within an entity so that they can be better placed in an intensive care unit or on a floor. And so I applaud you for this because this has worked in practice, just like Dr. Kumar had said. Thank you.
Further comments or questions? If not, we'll be voting to send this bill as amended to, oh, pardon me. Chairman Terry, you're recognized.
Thank you. Did we have somebody that was going to go out of session to speak?
Well,
They were here to answer questions if
yeah, just,
if someone has them.
yeah, there were 3 people that were willing to answer questions, but apparently we have none. So that's up, sir, if you want somebody to speak, yeah, we'll recognize.
I would like to recognize someone that's here to
no
speak on this.
objections, we'll go out of session and recognize. Kathleen, go ahead and identify yourself for the record.
Sorry about that. Am I on? All right, Kathleen Murphy with the Tennessee Nurses Association. And I know I've spoken with a few of y'all about our concerns around this program. First, we would like to say that we're trying to work an amendment out with the Tennessee Hospital Association. There are a few areas of this bill that we think needs guardrails around it, not just to protect the registered nurse or the graduate student, the graduate nurse, but also to protect the patient and protect your constituents who are under our care. So one area is that we would like to see this tied to graduation in some way. So this would allow, under the current amendment, this would allow the graduate nurse to take time off from school. Maybe there was a health issue in their family. Maybe they were pregnant. Maybe they're moving across country to move back home from where they went to school. But this could allow them to take 1 or 2 years or more off before becoming a graduate nurse here in Tennessee. Now, the Hospital Association and others, we've had conversations about would the hospital or the employer employ that student that took the time off? Maybe yes, maybe no, but that guardrail is not in this legislation currently, and we feel pretty strongly that that's important, that if we're going to bring this program back and enter into it here in Tennessee, we need it tied to their graduation date in some way, so it is not an unended issue. Secondly, and most importantly, is this needs to have in the legislation a 1-to-1 ratio. The supervising RN needs to only supervise 1 graduate nurse at a time, because the nurse will have their own patients, the graduate nurse could have their own patients, and it exponentially will stretch out the RN's responsibilities. We don't want to put the RN at liability and risk. We do not want to put that graduate student at risk. And most importantly, we want to make sure that our patients, your constituents, yourself, your family members are taken care of here in Tennessee. I'm happy to answer any questions, and I hope that we are able to work out an amendment. I think that this could be worked out pretty easily if y'all wanted to roll it 1 week. I think it could easily be worked out by then. Happy to answer any questions.
Chairman Terry, I think you want to be recognized.
Thank you. And just for clarification, there are 2 issues, even as amended, that you see with the bill. One is that there's the timeline from time of graduation, and I've known nurses personally who have waited a period of time before they tried to get their nursing license, and so they're out of practice, and so I agree with you wholeheartedly on that issue. Secondly, the issue about 1-to-1 supervision, that's an issue we have discussed, and I've discussed it with others on this legislation, and without those 2, it's up to the will of the committee how this goes forward, but without those 2 things on this bill, I will not be able to support it.
Thank you.
We have further comments or questions. Speaker Marsh, you're recognized.
Thank you, Mr. Chairman. And, I might be mistaken, but I thought I heard when this bill was explained to me that there was only a limited for 120 days. Is that correct, or?
So the bill.
You're recognized.
I'm sorry. Thank you, Chairman. As amended, what would happen is once the graduate nurse gets their approval to take the NCLEX test, So that means once they've passed their background check, once their transcripts have been submitted, all of that, when the Board of Nursing says you are good to go to sit for the test, that's when that 120 days starts clicking. So that means that I could have graduated with a degree in nursing, we won't say how many years ago, but a few years ago, right? And I could just now start down this path, right? Say I had a different opportunity. I went to some sort of pharmaceutical something or other, or I went home and worked in my family business for a while before starting practicing nurse. Then, under this program as written, as amended, I could enter into this graduate program. And that's our concern is, well, we want nurses to feel comfortable. And so the Student Nurses Association, they have a representative on our Government Affairs Committee, and they have voiced great concern, great fear. They do not want to be put in the position of graduating and then going immediately to the floor without some sort of, well, first being tested for licensure, but also without these guardrails of where they may have patients, but they may have other people as well under this RN, and they don't want to take that risk. It's very scary to them. So we are asking you, we are nurses, we know what we can handle. Please listen to us and hear us when we say these are concerns for us doing our job to protect the patients.
Okay, Speaker.
Let me follow up with that. And is there a shortage of nurses right now in most places?
Yes, sir.
Wouldn't this alleviate some of that shortage?
This would allow, I'm sorry.
You're recognized.
Thank you. This would allow nurses to graduate nurses to get onto the floor 120 days faster, potentially. But I think that the shortage of nursing, well, again, speaking kind of away from this bill, the shortage of nursing can be fixed in a lot of different ways and should be fixed in a lot of different ways. We want new nurses to feel comfortable when they go on the floor to take care of patients. And we really feel that these two kind of guardrails are going to help assist and make this program better and safer.
Okay, thank you.
Chair Lady Smith.
Thank you, Mr. Chairman. And one thing I just wanted, and you may not have the answer to this, but what I'm hearing validates something. You know, when I got my BSN, I had 2 years of clinical nursing before I walked across. So I had been on med-surg floors. I had been in surgery suites. I had delivered babies. I had been in the ER. And so for 2 years, I did clinical. And so 120 days is really not going to make that much difference. However, one thing I'm hearing, though, is because we have a lot of online nurses programs, we've probably created a situation where they don't get enough clinical. And so I just want to go onto the record to say that these online nurses programs that are churning out a lot of people that have very little clinical are probably adding to this problem. And so I would just simply say thank you to the bill sponsor if you all are going to work together, but I think we need to look very carefully at how individuals are becoming trained in the state of Tennessee to become registered nurses if you're not able to go on to, when you graduate and you've done your clinical, people should have an assurance in that degree. And if we've got if I'm hearing this correctly, and we've got a problem with degree mills, and we're just churning out people very quickly for some kind of a franchise, that's a problem. But I'll let you all work this out, but I think it's a good idea. Thank you.
Further comments or questions of the witness? If not, let me recognize the sponsor. Is this an issue that you have discussed? Yeah, stay there just a minute. Is this an issue that you've discussed?
There has been discussions on it. Obviously, people don't always agree. One point that I'd like to make in rebuttal is that if a nurse is scared to be 120 days on the floor, then she doesn't have to participate in this program. She can stay at home and study for NCLEX. And so I don't think that from that standpoint, if a graduate nurse is not confident enough to go onto the hospital floor, they know that better than anybody, so that there's nobody forcing them to go. But what this does, it provides an avenue, a legal avenue, for those who want to do it.
So essentially, you've seen the compromise, but you don't want to add it to your bill.
Well, I also heard words from Dr. Terry, and I know that that's the next stop this bus makes. And so, I would say that if we were fortunate enough to bring it out of this, there would be continued conversation with this, but we'd love to move on if we could.
Okay, is,
Understanding the words of
Yeah.
wisdom and warning that we have heard.
yes. We have further comments or questions of the witness? If none, we appreciate your testimony. No objections, we'll go back into session, and I will be at the will of the committee. It's not I was told going into this that it was a given that you were going to consider that amendment were we to send it to the full committee, but that's not obvious, so.
Well, if, I'm seeing people, we didn't work on our signs for today, but we'll be happy to work it out, to roll it for 1 week, and we will boil this.
The chairman.
Oh, wait, we have
Chairman Terry, you're recognized.
Thank you, Chairman. I'm willing to work with the sponsor and those on this. If it's the will of the committee to move it forward and work on the amendment beforehand, I'm okay with that. Obviously, it's the will of the committee to do that, but I do want those issues addressed.
Mr. Chairman, I do know y'all
Yes.
are tired of looking and listening to me, so you might want to get me ended today.
Oh, okay, no objections. We'll move the previous question, voting to send this bill as amended with hopes of collaboration to the full committee. All those in favor say aye. Any opposition? So approved. Is he still here? Yeah, he's right there. Oh, I'm sorry, yeah. Chairman Boyd, you are recognized on item 6, 750. We have a motion and second.
Thank you, Mr. Chairman. This is an incredible bill. This creates a obesity task force, and I think it's ironic that I just carried a bag of Chick-fil-A in here as I get ready to present this bill. And I don't know how I was picked for this bill, but what it does, members, is it creates a task force. There are people that come from the medical industry. This is not a TASR study. And just to clarify, this is not to study what causes obesity, and this is not to study necessarily the effects. This is looking more at the whether or not there would be cost efficiency for maybe TennCare or medical insurance in general to treat obesity rather than the symptoms of obesity. And so I'll take any questions, Mr. Chairman.
We have Chairman Terry, you're recognized.
Question on the bill.
No objections. We'll be moving this bill forward to full committee. All those in favor say aye. Any opposition? So approved.
Thank you, Mr. Chairman, committee.
Okay. Item 7-1045 by Dr. Kumar has been rolled 1 week. Item 8, House Bill 829 by Dr. Kumar. Do we have a designation on that, sir?
Thank you, Mr. Chairman. I think it might take a little time, considering the time
Oh, okay.
constraints.
You'd prefer item 9, House Bill 180 by Chairman Hall. You're recognized.
Thank you, Mr. Chairman. House Bill 180 was brought to me by the Tennessee Firefighters Association, and this would require a healthcare providers that are caring for patients that display threats of suicide or bodily harm. Before discharging them, it would direct those to a mental health professional or counseling service.
Is that what he just described? Okay, there's an amendment on the bill that makes the bill what you've just described it. We have a proper motion and second on the amendment.
Yes, sir.
All those in favor of the amendment say aye. Any opposition? We're back on the bill as amended, I think, which you just described to us. 4631.
Yes, sir. That's the drafting code.
And do we have questions?
Thank you, Mr. Chairman. I know you say it directs them. Do they have to actually go to a service, or they just directs them to a service?
They don't have to. It directs them to to mental health facility or counseling, and gets them the proper help. In the past, we've had some first responders that have sort of fell through the cracks and have not really gotten the help they deserve. So this would give them the resources to seek the help that they deserve.
With further questions or comments of the bill? We've not, we'll be voting to send this to full committee. All those in favor say aye. Aye. Any opposition? So approved.
Thank you. Thank you, Mr. Chairman.
We've taken 10. I think Parkinson left, so I guess we will call for a motion to adjourn. And let me make an announcement that well, we run out of time. Who's coming in after us?
Insurance Subcommittee.
Are they going to be here?
Yeah, they are.
Okay. A couple of announcements. All the bills that we didn't get to today, plus item 8, which we chose, didn't have enough time with, we will move until next week. And if we're going to have the final calendar next week, for all of those that want a bill on the calendar, you got to put it on notice by tomorrow at 3:30. So no further comments or questions, answers. Sorry for those that we didn't get to. And we had a motion to adjourn, so approved.